Hello and welcome everyone. Can you see the slides? Yeah, great. This is really quite an exciting opportunity. Many of us around the table have been involved with AHANA since it started. AHANA is the Allied Health Assistant National Association and it's based in Australia. I think one of the things that we'll briefly touch on today is, how AHANA came to be formed and what we tried to achieve. But one of the things that we've really learned is exactly how hard it is to start a professional association. There was so much behind the scenes, and it's still largely being run by some very dedicated staff, and we're very grateful to Ty Chittick for that, and Dermot Clark, who does our comms, but pretty much all of it's run by volunteers. We know there's a lot of interest internationally in starting to set up and organise the Allied Health Assistant workforce, and we thought it was a great opportunity to share some of our learning and bring people into our international community, partly to so that you don't have to reinvent the wheel, but also for us to be able to share our resources and learn from you. I'd like to start by acknowledging the traditional owners of the lands on which we're meeting today. I'm based on the lands of the Arakwal people of the Bundjalung Nation in northern New South Wales, and I'd also like to acknowledge and pay our respects to elders past, present and emerging, and also acknowledge any First Nations people who might be here. And I also acknowledge that we have some international presenters and recognise the First Nations people from wherever you're joining us today. This is going to be an interactive session, so just at this starting point while people are still joining us, if you can get your mobile phone and scan the QR code, you'll be able to join us through the Slido, and we'll be having some 3 interactive questions throughout the session. If you don't have a phone or would rather join us on your PC, you can cut and paste the link and insert that into your browser, and you'll get a link on your computer. But what that means is as we get to the questions on the screen, you'll be able to answer those. Can anyone pop their hand up if you're having any problems with that? Otherwise, I'll move on. Right, I'll keep going. Just to let you know, we've had a lot of international interest. For those of you that have just joined us today, this originally came about because we started talking to Ryan Rogers, who's based in New Zealand, because there was interest from the New Zealand Allied Health Assistants in potentially joining AHANA. But we've also had quite a lot of interest from Allied Health Assistants and support workers in the UK. We had registrations from Singapore, and we've also had people interested in Canada. We know that the time difference doesn't suit everyone, and we will be holding other events at times to suit people around all parts of the globe. So this is a free session. It's to look at how Allied Health Assistants and support workforces are really emerging and growing in different countries, in different contexts, and to share our learning with each other. And today's question is really to look at the role of a professional association in strengthening the identity of the Allied Health Assistant and support workforce in your context, and how we can share that. We've got a couple of presentations, and we've got 5 Allied Health Assistants with perspectives from Australia, Canada and New Zealand. But we actually really want to hear from you. So I know we've got a lot of people, and that's the reason we're using the Slido, to keep it as interactive as possible. I'm just going to give you a bit of a brief background about AHANA. I won't go into this in a lot of detail. There's quite a lot of information available on our website, and we've also got a number of videos on our YouTube site if you want more information. But essentially, we were founded in Australia in 2022, and there had been a history of quite a well-established network before we formed the association. And what the association did that the network couldn't do was form a company limited by guarantee and establish a board. But what was really important was that we have set up a structure for effectively creating a certification framework for the Allied Health Assistant workforce. So we've been able to create a quality framework. In Australia, about half of our allied health workforce are not registered by the country. They're not registered with our allied health assistant, I'm sorry, the AHPRA, the Health Practitioners Registration Association. They are self-regulated, and this is the model that is used by the other half of the workforce: speech pathologists, dietitians and exercise physiologists, etc. So we're a national peak body for the allied health assistant workforce, and our jobs are really advocacy, and we've done quite a lot of advocacy nationally and at a state and also with different organisations, supporting professional development and starting to build a sense of belonging and community for the allied health assistant workforce. So in Australia, we do these 4 things. So first of all, as I mentioned, we provide a certification scheme for the allied health assistant workforce. So what that means is that every practicing member that applies to become a member of AHANA has to go through a bunch of hurdles. They have to demonstrate qualifications or equivalent. You don't have to have a qualification to be an allied health assistant in Australia. And or work experience, and you have to have insurance. So those are the 3 things that we'll judge you on. And we have a tiered membership structure. So people that don't have any qualifications and are newly graduated are eligible for provisional membership. Once you've got some qualifications, it might be a Cert 3 or a Cert 4, and or some equivalent experience, you're eligible for general practicing membership. And for people with a certificate for and at least 450 hours practicing as an allied health assistant, they'll be eligible for certified practicing membership. So Ty is our membership officer. I don't know if you want to wave Ty, and he assesses every single application that comes through our doors. Anything that doesn't fall within those categories, we send off to our another subcommittee of our board who'll assess it for eligibility. We also have a public register of allied health assistants. That is voluntary, but we do strongly recommend that people are on the register, and we hold you to account to a code of conduct, and you need to demonstrate that you've doing at least 20 hours of continuing professional development, and that's structured and at the moment, and we provide support around that. I'm just going to quickly open that up to the directors on the meeting. Have I missed anything that we needed to touch base on here about the membership? So really what we're hoping to do today is create an opportunity for more people to participate in the structures that we've enabled through AHANA. We're interested in the idea of a global community, and the interest we've had in establishing this meeting suggests that there is interest in at least having a global discussion. We will also provide access to our CPD structures. We'd like to explore the opportunities around building a professional network. At the moment, we provide 2 newsletters a month, and that will be the new format for distributing our CPD. We have advocacy in Australia, but if we have enough members and enough support, then there's the opportunity for us to build those networks in your own country with your own support, but use AHANA as a base, and also for us to share and learn ideas. I guess the point I really want to make today is that the international membership is not the certification structure. So you won't be able to say that you're a certified practicing member of AHANA, but you'll be able to say that you are an associate member of AHANA. So you've got the members, if you join, and that's not compulsory, obviously, but you'll have access to our membership perks and benefits. So the first thing I'd like to do is, first of all, welcome everyone that's joined us, and we'd love to get your voice now. If you haven't already got access to the Slido, please scan the QR code that you can see on this slide, and we're going to get you to answer the question in one word: how would you describe the current identity of the allied health assistant or support workforce in your country? And once you've got the Slido code up, the question should pop up now. Okay, there are some optimistic terms coming up and some I mean, we know this is a really new and emerging workforce, but I think this is really important for us to understand where you're coming from. Not established yet, ongoing, passionate, that's a nice adjective. Progressive, maturing, segmented, not professional, hidden, invisible. I think the two biggest words are really quite, they're quite nice terms. First of all, undervalued, which is, well, it's a bit negative, isn't it? But emerging, it sort of shows the maturity, the relative maturity of the allied health assistant workforce in our respective jurisdictions. And we know that one of the challenges that we have is visibility and being able to be counted. And so this is really an opportunity for us to get together as a group and hopefully start to address some of these issues. So I would say that the challenge and the opportunity for us is to take that positive word, emerging, and use it to start to turn around the negative one, which is the undervalued. Before I go on, can I just check that whether anyone's had any problems getting access to the Slido? All right, I'm not seeing any hands. I'm going to now hand over to our panelists who are going to give us their perspectives on their countries. I've asked our respective panelists to give us what we're calling a 3-minute workforce passport, and we've got perspectives from Australia, New Zealand and Canada. And I've asked them to talk about what does the workforce look like in your context? What's one thing that you think is working well? What's a significant challenge or barrier? And how can a professional association or network contribute? And I'm going to start with the chair of AHANA, who has kept us on the road, Andy Richardson. Go for it, Andy.
Lovely. So to start with the name of the workforce itself, so obviously the umbrella term here in Australia is the Allied Health Assistant, but as we found out, especially through the disability sector, any allied health provider can call their AHAs anything under the sun. So they're known everything from allied health assistants to clinical assistants to physical therapy aides to habit coaches. Who really knows? It's a fun and creative space in order to build up. One of the positives that we've got at the moment is there's all this very exciting upcoming research around the benefits of the AHA workforce and how they can be implemented within an allied health multidisciplinary team. And it's very, very exciting to see that there's some bodies of work like that that are starting to come out. One of the disappointing things that we seem to see is the lack of recognition within the AHA workforce that we are our own specialized workforce, because there aren't just AHAs working for a singular discipline anymore. There are in certain areas, but there are a lot of AHAs out there now that are interdisciplinary or multidisciplinary, working across multiple disciplines within a singular team, within a singular service. And then so that should explain on its own that we are more than a one show pony. So one of the main reasons for AHANA is we're able to provide that voice and that unification for that AHA workforce to say that we are specialized and we want to continue to advocate for them moving forward. And I forgot my last point. What's the last point, Susan?
The last question is, what could a professional association or international network contribute?
Oh, wonderful. And just opportunities like this. So advocacy and connection with other countries. So it's like we're trying to do what we can based on what our members are currently feeding back to us. And obviously, as we continue to grow and our membership continues to grow, then we can only improve ourselves. And then our connections with other countries will, of course, benefit that as well. So it'll be very exciting to see what the future holds.
Thanks, Andy. While you're listening to this, the next little slot will be an opportunity for you to, you, the audience, to tell us what you want to talk about. But please keep a note of any thoughts or questions and feel free to drop them in the chat if you'd like to. I'm going to go to Tara next. Now, Tara is a very interesting allied health assistant, originally trained in Canada and now works in Darwin, and has been one of the founders of AHANA. So Tara comes with quite an interesting perspective. Over to you, Tara.
Thank you, Susan. So first of all, I just want to tell the listeners today that what I'm about to speak about are just my opinions and perspectives after working in Canada. I haven't spoken to any Canadian health system or representatives to support the content that I'm sharing. This is just from my own experience training there and working in that country, which I still call home. Also. In the Canadian context, it's, as I said in the first slide, it's very segmented. So they all practice, everyone practices under the College of whatever discipline. So College of Physio, College of Speech Pathology, and College of Speech Pathology. There's no APRA that brings it all together. As a consequence, assistants are quite segmented into those disciplines. So I trained as a physio and OT assistant. It's a 2-year diploma program. You also would see social service workers by province as well. It's very provincial, which is our state and territory term, very provincial oriented. It's not national. Speech pathology has speech communication disorders assistant, which also brings some audiology into that, as well as another example, podiatry, and they're all regulated by their individual disciplines. As in the courses that are offered are accredited by them. One thing that's currently working well is that the time given to each discipline within the training allows a more thorough, in-depth approach to the discipline that you're studying. So I can definitely see that transitioning from the role in Canada to here, that I'm more job ready and have sort of, because I've been able to deep dive a bit more into the discipline that I've studied. Significant challenge though is that the scope is well established as well as a result of that. A challenge is that because you choose your discipline and your client, your employment, as well as your client involvement is limited to the discipline you've studied. So it limits PD opportunities, and also you can imagine the impact on the clients that we see, which are at the end of the recipients at the end of all this. There's extra people seeing them when you involve a clinician and an assistant. That multidisciplinary lens is less established. A professional association or international network, if there was one in Canada for all the assistants, I think it could facilitate networking opportunities across regions. As I explained, it's very provincial in how it's all regulated versus national. Across regions and disciplines, foster collaboration, and create a stronger, more unified professional identity, as well as more interdisciplinary learning, which doesn't always take place. So that's a bit of a snapshot on the Canada outlook for, I would say, a physio OT assistant or communication disorders assistant, podiatry assistant, as a group of allied health assistants.
Thanks, Tara. Just a point of clarification. I know Canada is highly, a bit like Australia, a highly federated model with different states having quite different health systems. Do you think there's a consistent way that allied health assistants would be seen or valued across Canada, or would it differ quite a lot by the different states? Or sorry, what do you
provinces?
Provinces.
Yeah. Thanks, Susan. That's a great question. I think that, so I'm from Ontario. That's the province I studied under and worked in. And I think similarly across provinces, the scope is a bit more well defined because they do have similar training, but still regulated by province, provincial, but we don't have much in the research, right? And in activities, British Columbia is quite a well-known province for research and for allied health in general. I guess you become more known for that. I don't know if that really answers your question, but in Ontario, we don't have a lot of connections with our colleagues in other provinces as a result of that. Does that answer
Thank
your
you.
question?
It does. And I think one thing that's interesting from an international perspective is understanding where and how the allied health assistant or support workforce is organised, but we can explore that later. Thank you.
Thank you.
I'm going to move to Kylie Hines next, who is a newer member of the AHANA board. I think you've been on it for probably a couple of years now, but Kylie is probably known to a lot of people here because she's been actively involved in coordinating the Monash Allied Health Assistant Day, which we are very happy to support and hopefully collaborate with. And for those of you that join, we will also be able to provide a discount code for the Monash Allied Health Assistant Day, which is in November, isn't it, this year, Kylie?
Yeah, November the 11th. Thanks, Susan.
Over to you anyway.
Great, fabulous. Thanks, everyone. So I'm an allied health assistant. I've been an allied health assistant for about 15 years and had some amazing opportunities. And I'm sitting in a governance role here at Monash Health. So I'd say in Victoria, our allied health assistant workforce is maturing or mature, quite mature compared to other organisations and networks. So I think what's working really well is we are increasingly having a good professional identity in Victoria. And I think that is partly because of the Monash Health AHA Day that we run in November every year. And we have international, we get a lot of people from New Zealand attending. So it's actually an international event now. I think the work that was done on the Victorian workforce recommendations was pivotal in establishing a set guideline on how we train our AHAs, or recommendations on how to train AHAs, how to work with AHAs. And there's a lot of resources that are actually on the Department of Health webpage. So I think that well-established framework is there for us here in Victoria. I think there's the challenge for allied health assistants is a career progression. So I'm very, very lucky and I'm grateful for the leadership that we've had in Victoria. So the leadership that we've had for about 15 years at Monash Health in establishing the governance role. So having allied health assistant governance set aside rather than everyone doing their own thing is really, really important for allied health assistants. So I actually oversee to make sure that people coming into our organisations have the correct training, they're meeting their requirements for CPD. So having that overall overarching support is really important. The challenge, I think, for us is a career progression pathway. So in our award, there's a grade 1, 2 and 3. There's just no official career progression for allied health assistants, not recognising that we can actually be leaders in our own space, like what we've established here at Monash Health. If anyone wants to talk to me about that, you can take that offline. I'm more than happy to talk about that. And I think having an international membership is really that advocacy and connection, which is so important, and making sure that we're involved in conversations, the national allied health conversation, which sometimes excludes allied health assistants. Like, we're integral, we're working in close partnership with our allied health professionals. I think we need to make sure that we're there in those conversations. Sorry, is that too much?
Oh, that's perfect, Kylie. And look, Kylie, I think one of the points that you've raised that's really important is Victoria as a state has embraced allied health assistance probably before any other jurisdiction, but you're also in a very mature organisation. So first of all, there's a lot of great resources on the Victorian Department of Health and Human Services website around allied health assistance. But the question I'd ask you is, to what extent is your experience at Monash replicated across the state? Are you kind of a unicorn in that you're really well developed, or do you think the allied health assistant role is quite well established everywhere in Victoria?
I think it's established, but I think that governance and the leadership of it is becoming, it's emerging through. So I have health networks reaching out to me saying, we want to get to where you are, but I have to sort of pull back and say, okay, so this was a 15-year project that happened over time. So you can't just sort of drop in and get to where we are immediately. So I think it's just getting organisations to understand you need to build up, see where you want to get to, and then build up to that. So giving the AHAs, having a governance model, a structure there, and then giving the allied health assistants within that organisation the permission to be leaders in their own space and build up that leadership capacity.
Really important learning there. And again, these are things that we can start to share as a network. Thank you. I'm going to finish our little discussion with Ryan. Ryan Rogers is from New Zealand. Well, originally you'll be able to spot where he's from his accent. But it was really a discussion with Ryan about the possibility of allied health assistants from New Zealand joining AHANA that started the discussion that we've got today. I think we're at fairly early stages in that discussion and probably need to sort out some of the detail, but I might hand over to you now, Ryan, to give us your perspective on what's happening in New Zealand.
Kia ora, thank you. Ko te rana te whakapaparanga mai, ko kritu te mauna, ko speti awa no ko te rana o, ko Aotearoa te kainga ki whanganui atara o e noho, ko Ryan toko ingoa, thank you. So yeah, I'm Ryan. I work here across in Aotearoa, New Zealand. I have been in this country for about 10 years now, and I can see a couple of New Zealand names pop up in the participants of this. I work in the public health system. I have done that for the last 9 years here in New Zealand. As Susan was saying, it was a bit of a chance conversation that occurred and opened up this opportunity. I'm going to talk a little bit more similar to what Tara was saying. This is my perspective of where we are, and there are regional variability in where we are in our allied health assistant workforce. They are known generally across here as allied health assistants, although again, traditionally we had our physio assistants, our OT assistants. They work generally in the public health system. We've moved away from profession specific into the more multidisciplinary approach. There is variation in private, so we do have some foot care assistants, and there's micro-credentialing you can do to become what is a podiatry assistant or foot care assistant. And there is some work going on in the background to credential some of those things. Anybody who works under delegation from a registered clinician, so generally physiotherapy, occupational therapy, social work, speech and language therapy, dietetics, are our AHAs. But there's another term that's used across here in Aotearoa, which is kaiawhina, which is any unregulated worker. But that also spans into things like healthcare assistants from a nursing perspective as well. One thing that's currently working well, and again, I'm going to talk from a public health system perspective, is that we have a growing number of staff and a really positive attitude from those staff of wanting more and wanting to step up and do more and be able to do more. But scope of practice or lack of scope of practice is a challenge because their roles they don't have a scope to work to. So we do have delegation frameworks that we utilize and have developed in conjunction with our clinicians to try and keep that, to keep some regulation and keep some safety for the clinicians, not just our AHAs, but also our registered clinicians who are delegating as well. We, again, similar to what people have mentioned, we have a lack of unity and a lack of kind of career structure for our AHAs. They go up and again, I'm going to talk from a public perspective, they come in at one pay scale and it goes up for a number of years, and then there's nothing. But there's no currently availability to push that as it stands, which is a challenge. And there's definite want from the clinic, from the AHAs to do that and to be able to do more. And kind of what Kylie was talking about as well is have their own leadership. You know, they're not regulated. And again, it depends on the hospital and depends on where you're working as to if there is any governance over them at all. It just so happens I had an interest in this, and part of my role in the health system down here in Wellington has an aspect of that. And what could a professional association or international network contribute? Well, learning opportunities. That was the biggest thing that came out of our AHA. We ran a study day similar to what Kylie was talking about for the Lower North Island, and the biggest thing came out of that was they want more learning opportunities. They want a voice to unify what they are thinking about and how they can progress as a group, as a profession, as a as a support network, but also those networking opportunities to meet people who are doing similar roles, and the same way as every physio might want to meet another physio who's doing the same thing. And also, I think someone touched on research as well. I think there is an opportunity in there to look at how we utilise our AHAs and what value they bring to our workforce, because they really do bring in a huge amount of value. Thank you.
Fantastic, thank you. Look, I think already the breadth of conversation that we've had in just, well, 15 minutes has shown there are a lot of common issues and a lot of learning that we can do from each other. And one of the points that came up in the first Wordle discussion was, we're so fragmented, everyone's reinventing the wheel. So I think there's a real opportunity just to to understand the kind of model that you're working within, Kylie, and understand the kind of systems that we're all working within, and share that learning. So at least you've got examples that you can take back to your own country, employer case study, and hopefully lift the whole game for everyone. I've got a list of discussion topics, but before I go on to those, I'm just going to open it up first of all to the panelists to ask whether there are any final questions you'd like to ask of each other, or other points you would like to make as a result of the discussion of what we've heard so far.
I'll just also echo the thought that for leadership opportunities in Canada, once you, there's none really, you've done your discipline specific training, you choose to find a job in that area, and then the opportunities for leadership in that are likewise very minimal.
Thank you, Tara. And you, oh, Cherie.
Hello, Tara.
Hi, Cherie, I saw you on there.
Yeah, I guess just noting, and I'm coming from a vet perspective, so the beauty, I guess it depends how you look at it, but the beauty of vet is that we're very specific in regards to talking about scope of practice and what those specializations that are existing that sit underneath the Cert 4 in AHA provide a very clear guideline as to what can and can't or shouldn't be exceeded. I guess we still come back to being supervised by the allied health professional. And when we're talking about pathwaying, I've looked at, there's been a few diplomas on offer, but they sit outside vet. They're basically a higher ed creation. But even then, at the outcome of those, the options there are you become an allied health assistant, same as the Cert 4 really. And I'm not sure of the scope difference there. I haven't got into the diploma to that level. But I think it's really important to note that, when we look at pathwaying and options and recognition, what is the next step? And it seems to be the assumption that they will go into uni and specialise as either a physio, occupational therapist, etc. The only sort of recognition that we have in vet is that we allow the existing qualified allied health assistants to oversee and supervise and work alongside those that are students. But of course, both of those are sitting underneath the allocation and supervision of an allied health professional. It's very difficult. There doesn't seem to be a clear path for advancement, which is that motivation, and that ties into your retention and attraction strategies then for this field of work. And it's, it's almost like my impressions only, but you're sort of constantly trying to push yourselves at the table for the decision makers and the discussions about scope, because we don't seem to be recognised. And when I say we, I'm talking about vet. I'm actually a registered nurse, but I oversee the health portfolio for TAFE Queensland. So, and I see that happening quite a bit. There's a lot of discussion like we're having today. What is the outcome? Who do we have to door knock constantly to get this onto the table for recognition and value? Because I don't think this workforce is valued sufficiently at all, but I'm not sure what the outcome is to get it there. Thank you.
Fantastic points, Cherie. And I'm just going to tag a couple of points that you've made. So one is uneven education pathways and what's the outcome. And the second point is supervision. And I think every single day we have discussions about supervision, delegation. So thank you. I think they're really important points that we will constantly come back to. Andy.
Yeah, the only other thing that I wanted to feedback on more so than anything else is as Cherie was mentioning, that misconception of what the purpose of the AHA role is, and that the expectation is that they're going to progress in order for tertiary education to become an allied health professional, whereas that is significantly not the case. So it's like a lot of the AHAs that we've been talking to, you can break up the AHA workforce nationwide in Australia into a few distinct groups. So yes, you've got the one group who is, you know, who has that forward thinking idea that they'd like to practice in an AHA role for a period of time because it improves things like, you know, improving their soft skills and their clinical judgment and their clinical learning about working with patients, and then they can potentially like step on to tertiary education in order to become an allied health professional. But then you've got other AHAs who are happy and love the role that they do, because when they're working within a team who has an understanding of their knowledge and their background and what their scope is, they can effectively delegate to them more consistently. That means that AHAs like myself feel more fulfilled day to day because, of course, we're always doing, you know, consistently the best of our ability within the role that we are, without having to have any concerns at the end of the day that we're not satisfied with the job that we're doing, and that we're happy where we are. We're just not happy with, like, you know, recognition that comes in from those that don't understand the AHA role, from differences of pay from state to state as to what is deemed to be, you know, financially appropriate for paying an AHA, and how those seem to vary between sectors, between public health and disability and private practice. And it's just trying to, yeah, keep those discussions going, that, you know, there are people who enjoy the role of the AHA and like that particular role and would like to stay in that space, but there are other avenues where people can use it for a pathway if they'd like to.
Thank you, Andy. Tara.
Cherie, I think it's really important with your comments to also acknowledge that there are sort of like quite big differences between the public sector and the private sector when we're talking about this issue as well. I'd love to hear from Ryan after what the approach is in New Zealand and whether there is a public and private sector there, but in Canada there's not. There's only public sector health available. You can't elect any private support of any sort. So that also helps determine the scope, as we're saying, because there's not the differences in the supervision and delegation for a private sector versus public. The last thing I'll comment on is I went to visit the hospital here recently, and they've come up with, for example, 22 things just within occupational therapy to deem their OT as their allied health assistant competent. So I think in the current way that TAFE is set, and this is just my opinion, I'm still quite new in the TAFE sector, but how can, and that's just in OT, there's a whole list for each discipline. We can't cram all that learning in within the time frame of a 12-month delivery. So I think that's something that needs to be examined as well.
Thank you, Tara. Moira Scary, I saw that you put your hand up and took it down. Did you want to make a point, or have you had it answered?
No, is this still the panel?
It is still a panel. Oh,
yeah.
No, you're welcome to comment now.
Oh.
We've got a free for all now. So anyone wants to comment, please do. Yeah.
Yeah. So I'm not a health practitioner, but I am a specialist in service systems. So I'm really keen to understand, first of all, whilst you are working under supervision, is it correct that it's in a physical sense? You've got to be co-located? Okay.
No,
so,
not necessarily.
Okay, so I'm just curious then, I would see that the role of the allied assistant is critical for being able to deliver services in either thin markets or where there are, underserviced markets. And I'm wondering whether or not that's being studied in a structural way, and where that research might be, if it's anyway.
Rather than answering that question today, because I think that is something that A, we can partly address, but B, if we go down that rabbit hole, we'll take up the rest of the session, but it's a really important point. And we would like to engage with you on it. But I think there are, so if we can hold that, and maybe we can, I mean, we'll have other fora like this, but I think the answer is yes, it has been used to meet underserved populations. The issue is, of course, you don't want to reduce quality and safety for those populations. And the first point you made around supervision being in situ, again, it comes back to the question we get asked every day, what does supervision mean? And the answer is it depends. So
yeah,
sorry.
and then I guess my other question is, whilst I'm hearing about all the learning, I'm also hearing that there's also a lot of experience. So at what point does that experience cross over with the learning? Like with AQF, you know, their depth of learning also equates to levels of experience.
Yeah. And that's another really important point that I think this group needs to acknowledge. We sort of get stuck at an AQF level 5, I think, Cert 4, and there's really nowhere to go from that. So there's no joining bridge. So again, that comes back to the education pathways. But yeah, they're really important points, and I think this is why we need this kind of group to start to answer those. Melanie.
Hi, hello. I come from the public health and community health. My role is a advanced clinical assistant. Now, under our public health, we have different kind of name. Some allied health assistant, some therapy aid. Where I work, we call it advanced clinical assistant or clinical assistance for a bit lower level. Um, I work in this role for about 6 years now. Now my current role is advanced position. So it's just like similar like what Ryan talked about under public health. We do have similar things like each year is level up for our level, but also that is level 3. We call it like allied health assistance level 3, or our role call it clinical assistant level 4, because we advance, so we are in the level 4, so CA4. So usually CA4 is more independence than CA3, more supervision and things like that from senior level. So in terms of supervision, I do provide supervision for inexperienced clinical assistant under my role. So we have this kind of like 3 different kind of supervision under public health here. So we got like operational supervision, professional supervision, and peer group supervision. But what I provide for inexperienced clinical assistant, I provide professional supervision. So they kind of different thing. And the thing is, I love my role. I love what I'm doing. So in mental health, community health is quite different for clinical assistant. It's not like in hospital setting. They are more organized and structured in hospital setting because you know, maybe every hours you have to do different things with the patients and things like that. But in mental health, it's quite unstructured, which is quite really hard for me to figure out what I can do, what I can't. But the thing is, under my supervision from my supervisor, my own supervisor, we kind of like receive some guidance what we can do and what we can't. But still, like as a clinical assistant here, it's just still like there is a fine line between support worker and allied health allied health assistant or clinical assistant, because our role as a clinical assistants, we're not going to help the client or consumers doing shopping every day, or just doing the house cleaning or things like that. It's not. But yeah, there is no kind of what structural organization that from the governance that okay, this is a support worker, this is a clinical assistance role. So it's quite, that is a fine line. So sometimes the allied health professional got mixed up. You can do this. So yeah.
I'm sorry to interrupt, Melanie. Can you tell us where you are working? Are you in Australia or?
Yeah. I mean, sorry, I'm in Queensland.
Queensland. Okay, great.
Yeah.
Yes, look, I think the point that you've raised about the structures, it sort of relates to the career and the governance structures, and maybe that should be the focus of a future discussion for this group.
Yeah.
You've raised a number of important points. Thank you.
Yeah.
Ryan.
Yeah, I was just going to kind of say that again from across here in Aotearoa and in Wellington specifically, we have, you know, this encompasses not just our on the ward allied health assistants. This encompasses our dental service, who have their dental assistants. It has OT support workers. We have lots of different terminology, and when Andy kind of mentioned it earlier that there can be so much terminology. There's not so many of our AHAs work in private, and I wouldn't be able to comment on numbers. And as someone else alluded to earlier, there's not necessarily regulation or scope of practice for these clinicians at present, but some of the boards have been looking at whether they want to try and regulate, which I think is a big ask, and it will be very challenging for them. And then the other thing was just going to comment on, someone mentioned about level 3s and level 4s. So across here in Aotearoa, we have a level 3 health and wellbeing New Zealand certificate and a level 4, which is more of an apprenticeship style. They are not necessarily, they are good opportunities to do, and we would love for all of our team, all of our AHAs to have that qualification as they come into health, or be willing to work towards it as part of our governance over that as well, to ensure quality and ensure safety.
Thanks, Ryan. Some other really interesting points about, you know, identity and obviously safety and quality, and where practitioners are located. And they're things that we had to address when we were setting up AHANA. There's an interesting comment from, is it Zeni from Singapore? And I think that sounds like a really interesting framework, looking at a career pathway that looks at parallel allied health assistants and allied health practitioner staff. And we might tap you on the shoulder for a future session, or perhaps an article for a newsletter on that, because I think that's quite interesting. And the only places that I know that would be doing anything similar would be the NHS and potentially, and possibly Malaysia, because I was involved in some of that work. Look, I'm just conscious of time. I'm going to go back to the slide deck, because this is, as we said, just the start of the discussion. Sorry, Tara.
I just want to also comment that Canada as well, like to give you a small example, Canada have controlled acts that allied health assistants are not allowed to even go near. So there's a bit more information on each of the college websites in Canada for Zeni to have a look at as well.
Thanks, Tara. I mean, that's a really good point. I mean, we haven't even touched on the regulatory frameworks. We often have allied health assistants working within an unregulated model, but even the Australian and New Zealand regulatory systems are different. Even within Australia, the regulatory systems are different. So it's another point for us to touch on, I think, because it will really affect our roles and supervision and arrangements. Look, I put this slide up, or prepared this slide really just in case we ran out of discussion options, and we haven't. But and I'm going to ask for your feedback in a moment. I thought these might be the topics that would come up, and some of them have, but I would really love it if you could throw into the chat some of the topics that would be useful for you for use further discussions. What we had thought, or what I'd envisaged, was we'd run 4 of these international sessions a year, and our next one's in September, and probably repeat this format. But I'm already seeing that there are enough common issues that we should probably have a structured discussion about regulation, supervision, training pathways. And if we got 4 of those in a year, that would be really a great topic. But it would be great to hear from you what you think those topics should be. And if there's anything else here, and I've already seen that there's been quite a lot of sharing going on. So I'll give you a moment to throw some things into the chat. The next slide I have is another Slido, and we would really like your opinion on what we can do to support you as an international network, assuming that you want the international network to go ahead. And I think there's been enough valuable discussion here, certainly for us to justify it on our basis, but an option you can put in the chat is you don't think this is useful. So we'd really like to know what, oops, I think I've gone to the wrong question. There, that's not the right question either. Sorry, let me just scroll through. I'm just going to quickly edit this one while you drop some things into the chat. This isn't really a great question, but hasn't updated either. All right, let's just do this one in the chat then. I was trying to be too good for my own good. So what we'd really like to know is what you would like from this kind of network, or some topics for us to help support you. So if you have a chance to throw those in the chat, we've got a few here. Professional regulation, professional recognition. Andy, your topic is on enterprise bargaining, is that right?
Oh, I'm just posting them up there for interest, because Queensland Health had a fantastic example where they've currently got a certain tiered level of AHA roles within the state, but in their enterprise bargaining agreement, they've already got pay points for potential higher levels within the state itself, so that if they get permission in order to be able to move into those roles, the pay structure is already in place. So it's one less thing they've got to sort out.
Yeah, great. Thank you, Kylie. Recognition as a profession in the National Allied Health Plan. For those of you in Australia, currently allied health assistants are excluded from the National Allied Health Workforce Strategy. Yeah, workforce and growth, education. These are all issues that we're grappling with regularly as an association as well, and we have very, very limited capacity as a volunteer group to deal with this. So we would also really value tapping into your expertise and capacity to build on this. While you're putting your ideas into the chat, I'll go on to the last Slido that will hopefully work, which is in 5 years you would like the allied health assistant or support workforce to be what? And you can answer with one word or a statement, whatever you like. But I think we need to end on a positive note. already these are the opposite of the negative things that we started with: appreciated, recognised, growing, supported and thriving, recognised as vital. While those are popping up, I'm going to, and I've got a couple more slides at the end of this, but I'm going to propose, our next one of these is proposed for the 30th of September, which is a Wednesday, at 5 p.m. Eastern Australian time. So we put it on the 30th of September because it's just around the time before everyone's clocks go crazy. So we think it's about 7 p.m. New Zealand time. We should be able to get 8 a.m. UK time. We should be able to get the rest of the kind of hemisphere between New Zealand and the UK. But we probably will miss out on Canada. I know that this time is probably, or earlier is slightly better for the Northern Hemisphere people, North American people. But I'm going to suggest that we focus on a particular topic and perhaps professional recognition and career pathways. Would that be something that would be of interest to people, particularly since we've had or seen already there's a great example in Singapore, and the issue of professional registration and regulation has already started to come up as an area of variation. If someone proposes another topic, I'm going to suggest that we do that for the next one. Speak now, forever hold your peace. Just in 5 years, we'd like the workforce to be independent and safe, recognised, leadership opportunities, valued and professional, acknowledged, professionalised for recognised professionalism, nationalised. That's interesting. If someone wants to tell us what you mean by that, that would be good. But I think all of these are pointing to sort of a general recognition of the workforce that we don't currently have. So given the time, I'm going to move on. So our last slide is if you would like to join as an associate international member. At the moment, it costs 99 Australian dollars, and international members don't have to pay goods and services tax. And we would love you to connect. The next one of these will be providing as part of our normal public service, but from next year, they'll only be available to members only. For your membership, you'll get access to our fortnightly newsletters and access to AHA CPD. We have monthly support sessions, we call them water cooler sessions, FAQ sessions, and we'll be holding these events quarterly, plus a great deal of advocacy. But I think 1 + 1 will make more than 2. The more people that we can get involved, then the more we can support one another. And I think already I've seen from this small gathering that there is a lot of learning to help us lift quite quickly. So I'm going to stop there. Any final points or questions that anyone has? Yes, go on.
The future looks bright.
It does, yes. Thank you so much for your participation. We're really grateful. We had 30 people here at the peak, which is great. This has been recorded and the video will be made available on the AHANA YouTube site, and we'll share the link in the newsletter, but I think you might need to subscribe to access the newsletter. Go to the AHANA website for other events, and we really hope that we'll be able to continue this engagement. Please join me in thanking all of our speakers and also thanking all of our participants.
Thank you very much.
Thanks, everyone.